I'll start by standing back here, but you may not be able to see me, so I may wander around a little bit as full disclosure. So just to start, I don't have any relevant disclosures other than I am a gynecologist. And nobody likes seeing a gynecologist, and certainly nobody likes seeing a cancer gynecologist. And so that's the truth of the matter. So what I'll talk about today is 5 things, and we'll move through as we can. So first we'll talk about what is prevention, and what do I mean by prevention when we talk about how to prevent these cancers. And also, what is screening? So what makes a good screening test? What diseases are appropriate for screening and why? And then what do our governing organizations say about screening, specifically with regard to cervical cancer and ovarian cancer and endometrial cancer? And then we'll take a look at what data supports these guidelines. So why are these guidelines the way they are? And then lastly, at the very end, we'll take a look at what we can do separate from screening to reduce our risk. So when we think about prevention, there are 3 discrete ways of prevention. So the first is primary prevention. So interventions before health effects occur through measures such as vaccinations or altering risky behaviors or banning substances known to be associated with a disease or a health condition, for example, smoking. Secondary prevention is screening to identify diseases in the earliest stages before the onset of symptoms. And then tertiary prevention is managing diseases post-diagnosis to slow or stop disease progression. A lot of what we'll talk about today is secondary prevention, or the screening to identify these diseases in their earliest stages. So the first thing to think about when we think about screening is what makes a good screening test? What is screening testing and why should we be doing it? And what specifically about the tests make them good tests? Well, they need to be accurate. If a screening test wasn't accurate, it wouldn't do anybody any good. Needs to be easy enough to perform, both for the practitioner and the patient getting the screening test. It needs to be acceptable. If it was horrible, nobody would get screening. And then ideally, in a perfect world, it would be low cost so that it could be implemented to everybody. So what about cancers? What cancers should we or can we be screening for? Well, the cancers themselves need to be relatively common. If we were trying to screen for cancer of the left pinky toe, that would be a difficult cancer to screen for. There ideally should be a period of pre-invasion or pre-cancer so that you can catch it before it becomes a full-blown cancer. Ideally, it would also be slow growing to give us time in order to screen for it and make a meaningful difference in the outcome. And then there needs to be a benefit. If you detect it at an earlier stage, can you do something about it to make outcomes better? Or are you just detecting it and it doesn't do anybody any good? And then lastly, it needs to be feasible to enact at a population level in a perfect world. Again, everybody should get the benefit of this screening. So risks of screening. Screening isn't completely without risks. So there's anxiety, there can be stigma. Example, things I'd rather do than get a pap test, get a paper cut, pour vinegar on it, shoot off my big toe. There's risks of a false positive. So you get a test, a screening test that's positive, but you're not actually at any higher risk. This can lead to over-testing, over-diagnosis, perhaps procedures you don't need, and over-treatment that can do you more harm than good. There can be discomfort and risks of additional testing. And then what about false reassurance? So I get a screening test, it tells me I'm not at high risk, but then you're actually at a higher risk. So the poster child for screening, what we'll talk a little bit about today, is cervical cancer. So cervical cancer, we know 99% of the time is caused by the HPV virus, or the human papilloma virus. There are multiple strains of the HPV virus. It's the high-risk strains that women get affected with that stick around for a long time that cause cancer. So let that stick in. This is one cancer that the vast majority of the time we know the cause of. And because of screening measures, we've been able to decrease the incidence and mortality of cervix cancer. So right now, cervix cancer itself, when we think about those things about cancer that makes them good to screen for, it is rare. So it's not common. So that doesn't fit exactly. But HPV infection is common, which makes it a good disease or condition that we can screen for. There's a clear pre-invasive lesion. There's something precancerous that we can detect, or cervical dysplasia, or CIN 2 to 3, or cervical intraepithelial neoplasia. You'll hear all those terms. That's a precancer. Cervical cancer has a relatively slow speed of growth. We know that it takes about 10 to 15 years on average in normal circumstances for women to get infected with high-risk HPV to develop all the way to a cancer. So there's time to intervene. And we know there has been enormous benefit to early detection. We've seen a 75% decrease in the incidence and mortality of cervix cancer over the last 50 years, primarily due to screening. And it's feasible. Pap tests, HPV tests are screening tests that are feasible. They're accurate, low cost, can be implemented at a widespread level. Which brings us to the discussion of ovarian cancer and uterine cancer, and specifically endometrial cancer. And endometrial cancer is a type of uterine cancer. The endometrium is the lining of the uterus, most common. So first, let's talk about ovarian cancer. It's rare. It is rare. Its incidence is only 1 in 70. It's not in the top 10 cancers that affect women. Unfortunately, there's no clear pre-invasive lesion or component. There's no way for us to say this area or this cell is at high risk to developing to ovary cancer like we can for the cervix, which makes it different. There's an unknown speed of growth, but tends to present in an advanced stage, suggesting it grows quickly. Presents late, women have bloating or nausea. There's no question we would benefit from earlier screening if it would be possible. We'd like to find a way to identify this earlier. There's no question. And as of now, the research has not identified any feasible screening strategy, either blood work or CA-125s, we'll talk about that, or pelvic ultrasounds. So ovarian cancer is clearly a very difficult disease to screen for. What about endometrial cancer? Well, it's common. So that works in our favor. It is common. It does have a pre-invasive component. The lining of the uterus can develop a hyperplasia, which is a precancer. So there's a chance to intervene. It's likely slow growing. That also works in our favor. Most are caught at an early stage, with postmenopausal bleeding being an early symptom. But would we benefit from early detection? Unclear, because the vast majority of endometrial cancers are caught at stage 1. We are able to intervene early, and women tend to do well. So again, unclear how much screening might help us. And overall, screening has been poorly studied. Endometrial biopsies and pelvic ultrasounds have not proven to be effective. So we'll turn now and look at these 3 specific cancers now that we've set the stage for why we may or may not be able to screen for these cancers. And first we'll look at cervical cancer. Before we do that, I will show you the vast array of governing organizations there are, all of whom make guidelines or endorse them. So it can also often be very confusing to figure out just who says what and why and when and how. So part of our job is to try to clarify these guidelines, as well as encourage you to ask your providers exactly what these guidelines are. So what about cervix cancer? We'll turn first to the U.S. Preventative Service Task Force, and it is clear. A grade A recommendation means absolutely recommended, should do it, should screen, and we know that, right? We've seen a decrease in mortality, a decrease in incidence. We know that women aged 25 to 65 years should be getting some kind of screening for cervix cancer. These guidelines change often. As of now, between 21 and 29, pap smears Q3 years. After 30, co-testing every 5 years with a pap and an HPV. There is some subtlety there, and that includes up to age 65. Almost all organizations support screening for cervical cancer. So who should not be screened? Is there anybody who shouldn't be screened for cervix cancer? Women younger than 21. We don't screen women younger than 21 because, as I explained, you need to catch the virus, and the virus has to stay around for a long period of time before we know it causes cancer. HPV virus is commonly contracted, but most of the time clears. So if we were to be screening women younger than 21, they might have a positive test, but it wouldn't mean anything, and it would lead to a lot of unnecessary procedures. So women older than 65, you're off the hook with a few caveats, being that you've never had an abnormal Pap test before. And that's again, because if you were to newly contract an HPV virus, it would take an exceedingly long period of time for that to be the case, that it would cause a problem. And then women who've had a hysterectomy, again, having not had an abnormal test before. And that means your cervix needs to be removed, just to be clear. So a total hysterectomy, if the uterus and cervix were removed. You're off the hook, don't need to be screened. Just to reiterate, importance of cervical cancer screening, hope I've convinced you, it's important. We know that more than 50% of the cervix cancers diagnosed in the U.S. are in women who were never screened or screened inappropriately. So what about ovarian cancer? So given that this can be such a deadly and important diagnosis, has screening ever been tried? So I'll show you here first, as we move forward, lots of people have heard about a CA-125. It's a blood test. It's a test that we use to monitor someone's treatment with ovary cancer. It is not a screening test and has not yet been shown to be effective for screening. It's approved for monitoring the treatment, not diagnosing ovarian cancer. It doesn't work very well. It's elevated only in 50% of early cancers, so thus half of early cancers won't even have this blood marker elevation. And it's not expressed in all women with ovary cancer. Not as helpful in premenopausal women, and we know that measuring it over time is better than a one-time test. So briefly, for the sake of time, I will just show you there have been two large trials looking at randomizing women in their midlife to screening with CA-125s and ultrasounds or no screening at all for the diagnosis of ovary cancer and looking at mortality. If you look at these lines, the red is the women who got the ultrasounds and the CA-125. The black is the women who had no screening. And you can see there was no difference in death from ovary cancer. And this was at over 80,000, around 80,000 women. The next study, even bigger, done in the UK, 200,000 women. And this time they tried two different ways of screening. One, CA-125 with an ultrasound if it was abnormal, looking at the change. The next screening test, looking just at ultrasound. Followed these women for a really long time, over 14 years. And if you look at these lines, they're about the same. There was a subtle difference, very, very, very small, in ovarian cancer mortality. Now, that's good, but it's tiny. And in the screening groups, if you look at the women who screened positive and who had surgery, 85% of them had surgery arguably unnecessarily. These women did not have a cancer diagnosis. If you look at this data another way, it would take 641 women would need to be screened every year for 14 years to prevent one death from ovary cancer. And it's not that that one death doesn't matter, but it's these 85% of women who had the anxiety and the unnecessary surgery when their screening test didn't actually indicate they were at a higher risk of disease. Were just no good. So because of this data, the USPSTF recommends D, grade D, for screening for ovary cancer. There's actually harm to it. It's that 85% of women who had surgery when they didn't need it. Then you look at the American Board of Internal Medicine and the SGO, the Society of Gynecologic Oncology. Again, they say, don't screen low-risk women, asymptomatic women, because it could possibly hurt them. Then we turn to ACOG, the American College of Obstetricians and Gynecologists. What do they say? Again, the existing evidence doesn't support any test to effectively screen for ovary cancer. The best way to detect ovary cancer is for both the patient and the clinician to have a high index of suspicion for the diagnosis in symptomatic women. So what are the symptoms? What are the symptoms of ovary cancer? So this is a very large study looking in the last year, women who have had ovary cancer and women who just showed up for a clinic visit. What you can see is that women with ovary cancer had more pelvic and abdominal pain, had more bloating, increased abdominal size, and have urinary symptoms. I have all of them. You might have all of them. So how do we figure out which of these symptoms and how do we know? So another study went and looked at the symptoms of the women with cancer. They were more frequent than the women who didn't have cancer. So happening 20 to 30 times a month versus 2 to 3 times a month. They were more severe. They were actually for a shorter duration, so they were new symptoms. So women who had terrible abdominal bloating only for the last 3 months, as opposed to, oh, I've had it for 3 years or since I had my baby or that. And they were more likely to have a combination. So a woman for 2 months with abdominal bloating and urinary incontinence, never had before, bothers me every day, multiple times a day, please tell your doctor. Talk to your doctor about these symptoms, okay? So that's ovarian cancer. So let's move on to endometrial cancer, so cancer of the uterus. No major organization recommends screening asymptomatic women, low-risk women for endometrial cancer, as there's no evidence to recommend screening tests to identify that cancer. This is ACOG and SGO. Interestingly, though, if you look at the most recent American Cancer Society guidelines from 2019, they do say that women at menopause, there's no screening test, but they should be informed about the risks and symptoms of endometrial cancer and encouraged to report any unexplained bleeding after menopause to your doctor. So if I can stress anything here as a cancer surgeon, any postmenopausal bleeding or unusual premenopausal bleeding, especially with risk factors such as obesity or diabetes, requires an evaluation by your physician. Okay? So now what I've talked about is asymptomatic women without high risk, should they be screened for cervical cancer? Yes. Ovarian cancer? No. Endometrial cancer? No. But are there women who should be screened for ovarian and endometrial cancer? And the answer here is yes, but it's a very small population. And so these are women who carry a hereditary cancer syndrome, or BRCA, which puts you at risk for breast cancer and ovary cancer, or Lynch syndrome, which puts you at risk for endometrial cancer and colorectal cancer. This is a topic in and of itself, but these are the only women who should be going routine screening for endometrial or ovarian cancer. So what else can we do apart from screening to assess and decrease our risk of cervical, ovarian, and endometrial cancer in the time we have left? So we'll look at modifiable factors, factors that we can change. So for cervix cancer specifically, HPV infection puts you at risk, and the biggest thing I will highlight here is cigarette smoking. Decreasing your risk is vaccination. So if we look at prevention of cervix cancer, we can see, interestingly, that cervix cancer, even though we know 99% is caused by HPV, it's the 7th most common cancer to be directly attributable to smoking. My patients never know smoking hurts their cervix and your vulva, which is a topic for another conversation. But really not smoking is incredibly important for your genital health. We can see in this slide that the more you smoke, the higher risk you are. So 15 cigarettes a day gives you a 2.5 risk of cervix cancer. So what about vaccination? Briefly, who recommends vaccination? Like everyone. Everyone recommends vaccination, and I won't get on my soapbox here. I will just say recommended starting at 11 or 12, if not 9. It's up to 26 now. I happen to be 26. Way back when the guidelines were changed, I got vaccinated. And on a very personal note, my daughter will be vaccinated the minute she turns 9. There was recently all of this news about, well, the FDA approves the vaccination up till 45. Should we all go and get vaccinated up to 45? The reality is there's not enough data. There's not enough data. We know it's more effective the earlier you get vaccinated. So we don't really know in the population of women up to 45 if it makes a meaningful difference. It is effective. We don't routinely recommend it. It should be a shared decision making with your doctor. Let's say you've never ever had sex before and you're 43 and you're thinking about having sex. Well, maybe you should get vaccinated. That's true. So what about ovarian cancer? We know increased risk of body weight and cigarette smoking. The most interesting thing we'll talk about here is fallopian tube ligation or removal. Briefly, just putting it out there because everyone in my office told me I was going to have 1,000 people coming to get their ovaries and tubes removed, and I'm not saying that. So should I have my tubes and ovaries removed? No. Not asymptomatic women, not without a history, because we know your ovaries are important even up to 65. Your ovaries do things for you, so don't take them out. Deleterious effects for cognitive decline, Parkinson's, depression, sexual dysfunction, osteoporosis if you have your ovaries removed, and ovary cancer is extremely rare. So what about tubes? We know now that there's a significant portion of ovary cancer that actually starts in the tubes. So what we've falsely been calling ovary cancer is fallopian tube cancer. So should we just take out our tubes? The reality is we don't have enough data over a long enough period of time to say that that will work, that that will be effective. And there are risks of surgery, given that we don't know it's effective. But let's say you're going to the operating room, you're going to have a hysterectomy. It's the second most common surgery for women in the U.S. Should you have your tubes removed? Yes, that's what ACOG says. Should you, if you're desiring to have a sterilization, you want to have your tubes tied anyway, you're thinking about lots of different strategies, it would be reasonable if you're going to have surgery or have something done anyway to have your tubes removed because it also decreases the risk. Lastly, briefly, we'll talk about uterine cancer. The biggest thing I can say here is excess body weight. So endometrial cancer is caused by excess estrogen. Estrogen is caused by adipose or fat tissue. It converts it to estrogen. So obesity increases the risk for endometrial cancer as high as 10 times. We know a large weight loss may decrease the risk of endometrial cancer, as well as diabetes and heart disease and death. So those are other reasons if endometrial cancer wasn't enough. And obesity may, in fact, change how we as gynecologic oncologists are able to treat your endometrial cancer. Can you even have surgery? Or how do we dose your chemotherapy? And or can you get radiation? As well as how well these treatments may work. So in conclusion, running out of time here, to be a good screening test, you need the right combination of a disease that can be screened for, as well as test characteristics that work of the screening test. Cervical cancer screening and vaccination is effective. Low risk, asymptomatic women should not be screened for ovarian cancer and endometrial cancer. No shocker here, I don't have the secret for preventing cancer, but these things are very real. Important behavioral modifications include smoking cessation, weight loss, increased physical activity, and an open communication with your physician about symptoms that are concerning. We talked about the bloating and the pain, long, over months, multiple times a day, severe, and any postmenopausal bleeding. So it's truly an honor to be here. Thank you, and I'll be around later for questions.